Let's talk about WPW treatment. So vagal maneuvers. So what's the proper way to do a vagal maneuver? You can ask the patient to bear down, kind of like this. Another way is getting a 10 cc syringe, pull it out about 1 cc and have them blow into it. Pretty hard to do, try it once yourself. One of the other ways is you can get 2 other providers and you can both get on one side, have the patient, and you're both cradling the patient like this, with one of you holding a leg and you're kind of cradle them and you have them bear down like that. So you kind of have them in an L shape. Each one of you is holding a leg upright in kind of the bed, and you're holding them upright and they have them bear down. It's one of the actually more efficient vagal maneuvers if you can do it. Now, on a larger patient, it may be harder to do. So vagal maneuvers can be attempted first. Remember, if you're going to do the carotid massage, you're going to have here at the corner of the mandible, right here at the top of the thyroid cartilage. Problem is somebody has a prior stroke or CVA, or they have stenosis or any type of arthrosclerotic plaque. You want to avoid that. So there can be a lot of our patients, so that may need to be avoided. So the other vagal nerve maneuvers may be safer than the old school. Adenosine. Now let's talk about this. Maybe not. Maybe not, and then maybe only in certain cases. Now, first of all, when you give adenosine, there's certain rules you need to make sure that are followed through as a provider. You need to have the crash kit and you need to have the pads, either to front to back or side to side. You need to have that available. You need, excuse me, the adenosine, it needs to be pushed fast. It needs to be done by a nurse provider that is actually used to doing it, ACLS certified, and and it has to be done through a special stopcock in which you're able to flush it in as fast as it can possibly be. If you do it slow, it can have a paradox of worsening. Now, adenosine is good for SVT. Now, it can be useful in WPW only when the rhythm is a regular narrow complex, just as an AV reentrant tachycardia, AVRT. AVRT, it can be useful. AVRT in WPW is highly effective, adenosine is, and is generally safe in this context. Now, if it's irregular, like more of an atrial fib, what you're doing is you're knocking out the accessory pathway with this, and then you can go into VFib. So be very, very careful with adenosine. We talk about it, but you have this only in the regular. And the regular rhythms would be the AVRT, the AV reentrant tachycardia. IV verapamil can also be used and be very effective. IV procanamide can also be used, and we talked about that. And catheter ablation, if none of the else works, is you take out that accessory pathway. Procanamide side effects. So if we're giving a medication, we need to know the side effects. Can have a drug like lupus syndrome, a ventricular arrhythmia, agranulocytosis, bone marrow depression, neutropenia, and hypoplastic anemia. Also going in the same with agranulocytosis, the hypoplastic anemia, thrombocytopenia. Now let's look at some imaging. What do we have here? What do we have here? And you're starting to see these more on boards, and remember, you have to get proficient with ultrasound. If you're in the clinic, you're on the wards, ultrasound, they have handheld modules now, they're getting cheaper and cheaper. The stethoscope, we still need to use it, but it's becoming more and more chance of being obsolete. So what do we have there? This was a process of doing a central line and was requested to do a central line, and look what we have here. This is the right IJ. See this right here? That didn't compress, because guess what that is? It's a thrombus. So this gives a piece of data that you said somebody asked you to do a central line. You're doing a procedure, and then you notice a thrombus. So you know that something else is occurring in this patient. You don't want to push through that thrombus. So this is something else is occurring in this patient that will assist in management of this patient. So these are things you need to know. What's this? Oh, what's happened here? So this is a pacemaker, defibrillator, and well, we have this, but we got this right here, so let's go and see something else here. So we had the pacer defibrillator, got that right there, but look what here. Put a central line in, and what happened? It dropped over on the arterial side. It became arterial. This is an arterial placement line. It happens. You have to be able to recognize it. So what happens if an arterial line gets placed on the other side? Let's erase this and be able to kind of see this right here. All right, so erase it. Now we're saying, okay, we had a bad day, and we placed a right-sided CV. Look at that. It would curve over here. It goes past midline. Midline is here. It goes past it in midline. This is more than likely, unless they have something strange, and they have a nominate that goes there, or they have dextrocardia, this is where a good sign that this patient has what? A arterial placed central line. That's on the right side placement, and then here's an example of a left side placement. You need to know these, okay? It happens. You can be tested in boards. You can test it in the real world. All right, going again. Here's another example, and I want you to look at the mitral valve as we discussed before. Look at the mitral valve. We want to see, is it going to slap right here? This is right here, the anterior surface of the septum. Does it slap? No, it doesn't. This is another example of a low ejection fraction. This was estimated by a cardiologist at being 25%. Let's take a look at it again. It's a 25% ejection fraction right there. 25%. Now, you're not going to need to know, hey, what percentage is it? Because that takes a calculation. You're not going to be able to do that during an exam. But you do need to know, is it reduced? Is this reduced? And these are things that you can learn very easy. How to do is how to place that transducer on and quickly get a picture of what's going on with your patient. These are things, yes, do you need to get an echocardiogram? Yes. Do you need to get a cardiologist 3-day echocardiogram? Yes. Do you need to have an echocardiogram done by a registered echocardiogram tech? Yes. All these things to happen. But this is giving you data until you can get that information and take care of your patient. Here's another example right here. Look how barely moving. This is actually during a code. So looking during a code and seeing how our patient's doing. Well, this patient happened to pass, unfortunately. Look at that. There's no squeeze whatsoever. There's nothing going on. Mitral's doing nothing. Okay, we are doing nothing right here. There's global hypokinesis. There is nothing going. There is no squeeze on that heart. This is something you need to learn while doing codes, and so that way you can say, wow, we really have nothing. We have nothing. Now, let's look at a patient who has a normal ejection fraction, or maybe you could say slightly increased. Look at that. Look at that. Look at that mitral valve hit. It's hitting that anterior septum. Boom. See, it's like a hockey puck, and it's swinging up here. Watch it swing and hit up there. We're going to do it one more time here. Boom. Boom. Watch that hockey puck swing up and hit that anterior septum. Look at the global squeeze of this heart. Look at this. All right. Here again, here's another, see right here, we have a tricuspid vegetation, tricuspid vegetation. So these are things that you can learn. These are done by bedside. This was a bedside, and you can look and say, oh, we do have a problem here. All right, so take a look at this. This is no DVT. So, and we'll show you different ways of doing this. And basically, you're getting a linear probe, and you're pressing down, okay? Pressing down to see, here we go, we'll look at that again. And you're going to see right here, this is the venous, okay? This is the venous, this is the arterial right here. And we're pressing down, okay? And we're watching the venous collapse. Now, normally we can see the arterial still going. This is, we'll go and we'll get another example right here. So there's no DVT. So you're taking a linear probe. You can do 4 surfaces very quick. You can do the 2 femorals and 2 popliteal on a patient you're looking for DVT. If you really think there's one, you still can walk down the surfaces of these veins. Very easy. You can learn this pretty quickly. Now, in this, we're going to use color to see there's no DVT. So color gives flow, okay? It doesn't mean venous if it's blue. It doesn't mean red if it's arterial. It means flow. So look right here. Is we're pressing down. We're pressing down. So right here is the arterial, right here. That's the arterial. The other is the venous, okay? And we want to be able to press, to compress where we have no color flow on the venous, but we do want color flow on the arterial. So let's look at this again one more time. See, look, we're pushing down, pushing down, pushing down. Venous has collapsed. The venous has collapsed. The arterial has not collapsed. Do it one more time. That means there's no DVT in that spot. Okay, there you go, no DVT. Now, if they give you a still picture right here, this right here is a DVT. See this right here? This is a DVT. This is the arterial right here. This is a DVT in the venous side. Look at that, look at that. Boom, compressing down. Now here's another example right here. We're gonna go back, this is a still, okay. This is we're compressed no compression, so we didn't compress down. And then when we go to compress, if they happen to give you a still slide on this or a still picture in your exam, you see right here, this is where the venous surface is, and it's compressed down. There is no DVT. This is the arterial surface right here. Arterial right there, okay?